Ladies and gentlemen, dear colleagues, thank you very much for the invitation for that conference and the chance to talk to you. 17th World Congress of Anaesthesiologists, this time virtual, okay, every one of us had been more preferred to see each other live in Prague, but nevertheless, I think we are now familiar with online formats and give us a chance to discuss things and new knowledge also worldwide via this medium. So, okay, it's virtual, but nevertheless, I hope it will be interesting for the next 10 minutes. I'm invited to talk about CPR by emergency teams in hospitals for COVID-19 positive or negative patients. And I think this is a very important subject due to the fact that some of our treatment recommendation has changed, and we will see what changes are really important and what we can figure out at this stage from that knowledge, what we can find. My name is Jan-Thorsten Graesner. I'm the director of the Institute of Emergency Medicine at the University Hospital of Schleswig-Holstein, Kiel, the northern part of Germany. And you can see here my intellectual conflict of interest. So I have the great chance to be involved in different working groups dealing with cardiac arrest and with epidemiology, and also outcome analysis from cardiac arrest victims. When we talk about cardiac arrest in hospital, the so-called EHCA, in-hospital cardiac arrest, of course, this is something what will be important, and it will be a life-threatening situation with or without COVID-19. So we are all familiar with that situation of cardiac arrest in the hospital, and we know the treatment. Nevertheless, after we had a new player in the game last year, and it's now more than 18 months that we are dealing with that virus in the hospitals, it's very important to see if there are changes necessary, if we can treat victims better when they have a cardiac arrest with or without COVID-19 infection. And COVID-19, as you know, also very good, is may be complicated by pulmonary embolism, by myocarditis, by myocardial injury, or a myocardial infarction, the typical reason for cardiac arrest. And you have also problems in the ventilation system, you have problems with the breathing, and so you have a lot of good reasons to get a cardiac arrest. And COVID-19 and the virus is inflicting a lot of these reasons and can cause a lot of that reasons. So we have at the end, very ill patient in our ICU or in the hospital. So what means that what is the importance for cardiac arrest and cardiac arrest treatment? What also happens last year, we had a lot of publications. So we found, if you look in Medline, you can see if you put in hospital cardiac arrest in and also CPR, you can see for COVID-19 a lot of different papers and productive knowledge. I gave you two examples. I will bring you two examples and have the meta-analysis here done by colleagues from Italy. And they look at bunch of papers that are available and discussed and figured out some maybe interesting points for the beginning. A mortality rate of nearly 90% sounds high. Nevertheless, with or without COVID, this is a typical thing for cardiac arrest victims. So there is no high survival rate in the hospitals, and we saw some special hospitals and some well-trained hospitals with survival rate of 20 or 25%. And you can see here the forest plot of the results of the meta-analysis for mortality of COVID-19 patients undergoing in-hospital cardiac arrest and getting a CPR. You can see some are near to 100% mortality rate, and some have a better survival option. Normally, and we can see this also without COVID-19, this is not depending on COVID-19 or not, it's depending on the status of the patient, and also, and this is also important, the system, what is reacting on cardiac arrest, who runs through the system, who runs through the call, who will do CPR, is there a good basic life support team in the hospital, and this is also inflecting the outcome and has a major impact on outcome, not only infection with COVID-19, yes or no. So the colleagues from Italy put in their conclusion, our analysis provides even stronger ground for survival expectation, showing that the outcome of COVID-19 patients that undergo in-hospital cardiac arrest and CPR are indeed similar to the simulation of cohort selected. So at the end, it's more or less the same, but some things are different. Another paper, and published in British Medical Journal this year, looked at also in a multi-center study what happened in the hospitals. And you can see that nice picture here from the BMJ as a visual abstract. So I love that picture. So you can see on one page all the results. You can see it's more or less a big one. It's a 68 multi-center hospital study. We have more than 5,000 patients included. They are admitted to the intensive care unit with COVID-19, and 700 of them had a cardiac arrest. And you can see 63-year-old, more normally men, 65%. And these are the descriptions. This is not so much different from normal cardiac arrest victims, what we see in hospital in the time before COVID-19 occurs. And if you look at the numbers of results, you came out in that study and in that analysis with a 12% survival to discharge rate. This is average, but okay. And you can see the good neurological outcomes. So nearly to 60% of the patients that survived the event and had an outcome with alive. Nearly 60% had good neurological outcome. 40% have a bad neurological outcome. So this is also common for typical cardiac arrest situations in the hospital. You can see the incidence of cardiac arrest treatment is depending on the age. So if you're younger, people more often started CPR and your survival rate is also higher, the percentage and the discharge rate. And if you're older, the chance of starting CPR and also survival is lower than in the younger generation. So what did the colleagues conclude in this BMJ article? Cardiac arrest is common in critical ill patients with or without COVID-19. And in the age group of over 80, it's a serious problem. So the chance of survival are not so high. So you have to discuss before on the ward with the relevance. Is it worth the effort? Is the wrong word. But do you like to start CPR? Do we have a DNR order? What will happen? And so the ERC helped us with to answer the question of CPR, yes or no, in the latest guidelines. So many things are unchanged. You have to start and think about starting CPR, yes or no, best way before the cardiac arrest occurs. So you have to discuss with the families, shared decision making, yes or no. And if you have a cardiac arrest, start immediately. Otherwise, you have the problem that you have to discuss things, and things to discuss means no one is doing chest compression, and then people don't have no chance to survive. But new in cardiac arrest with COVID-19 is the discussion about the balance between potential patient's benefit and the risk to the rescue. And this is absolutely new. This was not a problem before for other cardiac arrest. Now we have to think about benefit for the victim, benefit or protection for our team. And CPR will also discuss if you have limited resources. So we talk about triage in some regions, and this is not typical for Europe normally, but we saw situations in Italy that they have no capacity on their ICU wards. And so they discuss, can we start or can we not start CPR? But again, this is something you have to discuss before and not in the real case at the moment. This is the decision that is, if it's good made, done before the cardiac arrest occurs. When we try to prioritize, we must be sure, as the triage situation always needed for, we must be sure that there will be limited resuscitations and resources, and then we have the chance to say, okay, yes or no, this is an ethical problem. And to put all the things together, the ERC came up with some guidelines adapted for COVID-19 and cardiac arrest, and we can see that the idea of aerosol generating procedure should be avoided. We must be safe that we don't do things that we and the team will be incorporating aerogen from the victim. And so the idea of checking for breathing is changed. The discussion about what do we do until we can start full CPR. Of course, we have to wear our PPE. And sometimes if you say we have a VF patient, so with ventricular fibrillation, it's a good idea to say, unless people are well protected with their clothes, you can start maybe with 3 defibrillations just to do something good for the victims. Otherwise, don't start CPR and prolong the time to start CPR will followed by less outcome. So there are some treatment recommendations, some ideas to change. And of course, this is only a very short presentation. So think about advanced things like advanced airway management, not late, but earlier, to stop that aerosol generation producers. think about doing chest compression by a machine, not by yourself, to keep the team away from the victims. And this are all things what we have to discuss and have to think about. So let me conclude, and my take-home message is outcome after in-hospital cardiac arrest is poor in patients with or without COVID-19. The current studies presented different answers, so we have to generate more knowledge, and important, find the balance between patient's benefit and the risk to the rescuer, and then we can always treat the victim and be clear and safe for our staff. Thank you very much.